Okay, why don't we try to get started? My name's Ed Howard. I'm with the Alliance for Health Reform, and on behalf of Senator Blunt, Senator Rockefeller, our board of directors, I want to welcome you to this program to look at what public programs and the healthcare sector in general can learn from some private sector stakeholders who are using a strategy called reference pricing to restrain healthcare costs while maintaining quality. Here's the 45-second non-expert version. Under this practice, the payer, an employer or a health plan, sets the reference price for a particular drug or device or procedure. The individual is then responsible for charges above that price. There are important nuances to this concept that I am ignoring for the moment, and you'll be hearing a lot about them in just a few minutes. The idea is to address the sometimes wild differences in price for the same service or product. I apologize to those of you who were here on Friday because I recounted this same anecdote. Several years ago, one of our board members noted that the cost of a specific surgery in one of the 50 best hospitals in the U.S. News list was double what it was for another of the 50 best hospitals a few miles away. And he asked, how can the best healthcare in the world cost twice as much as the best healthcare in the world? Same question has occurred to a lot of smart people involved in paying for healthcare in the private sector. And they came up with reference pricing as a partial response. And we've assembled several of those smart folks today on our panel to explain how this mechanism works, what the challenges are in putting it in place, and whether plans like Medicare and Medicaid could draw lessons from this experience. Now, we're pleased to have today as our partner WellPoint Incorporated, operator of the Blue Cross Blue Shield plan in more than a dozen states, which collectively cover about 1 in 9 Americans. And you're going to be hearing from Michael Bellman from WellPoint's Anthem Health Plan in a few minutes. Let me take a couple of moments to cover some logistics. There is a lot of background information, including biographical information about our speakers, in your packets. You'll also find in hard copy the PowerPoint presentations of our speakers. Those slides and all of the background material those of you in the room have in your kits are available on the Alliance website, www.allhealth.org. Also on our website, you can view a webcast of the briefing in a couple of days, and a few days after that, a transcript of today's discussion. Now, of course, if you're watching on C-SPAN, you have a video. You also have access to all of the materials I mentioned if you have a computer as well and can go on to our website, allhealth.org, and you can follow along with the slides, among other things. We'd ask you at the appropriate time to fill out a blue evaluation form to help us improve these programs as we go along. Make suggestions about speakers and topics that you'd like to hear from and about. And there's also a green question card. When we get to the Q&A, there are both microphones you can go to ask your question or to write it on the green card and pass it forward. If you're part of the Twitterverse, you can make use of the hashtag at reference pricing, as you see up on the slide that's in view now. And that's enough of the preliminaries. We have, I believe, just a marvelous assemblage of folks with knowledge and insight into today's topic. You'll hear their presentations, and then we'll get into the discussion and the Q&A. And we're going to start with Andrea Caballero, who's the program director at Catalyst for Payment Reform. And if you're not familiar with CPR, as it's appropriately abbreviated, it's a nonprofit working with large employers and other purchasers to improve how we pay for health services and to promote high-value care. Andrea's had a decade and a half's experience in healthcare with a focus on benefits and payment policy. And we've asked her to provide an overview of reference pricing today, how it works, and what some of the challenges are. Andrea, thank you for being with us.
Thank you, Ed. Thanks to the Alliance and for WellPoint for convening this really important meeting. I think you'll hear some really great case studies from the folks on the panel, and I'll be giving a background, and actually Ed gave actually a pretty good definition for on it. And I think CPR is Catalyst for Payment Reform, as Ed mentioned, is a nonprofit national organization that works on behalf of national large purchasers. We have about 31 purchasers that work with our group, and they include 8 state agencies. And of those state agencies, we do have 4 Medicaid plans. So to the previous point about can state agencies and Medicaid programs learn from some of this, I would say that at least in the work we're already doing, there's a lot of shared learning that's occurring. One thing that the CPR members agree to do when they join is to work on a shared agenda. And I'm not going to get into all of the details of our shared agenda, but the middle section there on the right-hand side will talk about our innovations, and I'm going to touch on 3 of those today. The first, obviously, is reference pricing and value pricing. The second is price transparency, and the third is market power. And all 3 of those items are really closely related, and you can't really talk about reference pricing without also talking about market power and the need for price and quality transparency. At its core, CPR has our strategies fall into 2 categories. And it sounds simple, but it actually can be kind of complicated. But basically, we're trying to create a critical mass of purchasers to send the same messages into the marketplace at the same time. And that's how we think we'll really change the market. We've got a lot of noise, a lot of people asking for different benefits, different payment, different ways of doing things, and that can really exacerbate confusion. So the CPR purchasers are trying to use common tools, common language, common priorities to send messages into the marketplace about what's important. And of course, the second is to shine the light on the urgency for payment reform, as our name is Catalyst for Payment Reform after all. So this might be a little difficult for you to see in the orange text, but if you look at your printed version, it might be a little easier. As Ed mentioned, reference pricing really is just setting a standard price for a drug, a procedure, a service. And then once you've set that price, that's the amount, the allowed amount that a health plan or a self-insured employer would pay. And above that amount, the consumer is likely to have additional out-of-pocket financial liability. If you look at the graph there, on the y-axis you see price variation. This is really just for illustration purposes. You'll see different variation in prices ranging from $1,000 up to $20,000. And then along the bottom you see the frequency of these services. And the blue line kind of shows how often are these procedures taking place and at what price, and then where do they go up. And this is the kind of analysis that has to take place. So you can set a reference price, but it's actually quite complicated in doing that. A lot of analysis has to go into that. I'll give you an example other than the way CalPERS and Kroger, which I'm sure they'll explain, but Safeway is an example where they did analysis of how much they were paying for colonoscopies in the San Francisco Bay Area. And the prices ranged from $900 to $7,200 with no correlation to quality. So that's an extreme variation in price. And once they did the analysis on the price and they saw the frequency of how many visits were at a certain price or below, they pegged their reference price at $1,250. So then their benefit design, as they implemented it, is that if you are a consumer, Safeway employee, and you seek care from a provider that is at or below the reference price, $1,250, then you either have no cost sharing or no or your regular cost sharing. If you seek a provider at that $7,500 at the top of the list, then you are going to be responsible for the difference between the $1,250 and the $7,200. So that's the mechanism of how reference pricing works. And some actually will consider it to be a pretty blunt instrument in the marketplace, and I think you'll hear how it's a blunt instrument, that it really is intended to shake up the marketplace and really shine the light on not only how things are being paid for, but what are the prices for things and how there's just extreme variation without any correlation to quality. I'm sure you'll hear from my colleagues that there are really 4 key elements of reference pricing. They'll probably go into more detail about these different elements, but basically there's benefit design. You really only want to implement reference pricing when it's elective and when you have a wide availability of providers. Obviously, this isn't going to work if you have 1 or 2 providers providing a service in an area. That is not going to create the level of competition that you need. So 1, the procedures have to be elective, and there's time to shop, and 2, there's available for multiple providers. The next 2 are really interrelated, and I think are very on topic for conversations in this room, which is price and quality transparency. You can't implement a reference price without giving consumers adequate information about the price of the procedure or the quality that they're receiving. Most consumers still equate higher price with higher quality, and we know that not to be true. So you really need to arm consumers with plenty of price information so they know which providers are at or below the reference price. And you also need to arm them with the quality information. How often are these providers performing these procedures? What is their volume? What is their outcomes? And if you have that information, then you can, consumers are better armed. But it would be really unfair to implement a reference price if you aren't going to arm them with that kind of information. That goes into the next one, which is consumer education. And I think there will be case study examples of how informing your employee population and educating consumers about the price and the quality and that the correlation between the 2 will be really very important, because you don't want consumers to get into a gotcha situation where they didn't know that someone was above the reference price and now they have a pretty extreme financial out-of-pocket liability. And then the last one is adequate networks, and network might not be an appropriate term here because usually these are providers within an already established network, so I use the term network loosely. But you want to be able to make sure that you have plenty of providers who can offer these services, these procedures at the reference price, so consumers have the ability to choose and they don't feel overly limited. They have plenty of options, including the option to go to seek the care from providers over the reference price, but that's their choice. I won't go through the detail of all of this, but this is just a schematic of the range of reference pricing. You can have very basic reference pricing all the way to really more mature and sophisticated. And CPR also likes to talk about value pricing. Reference pricing really refers to commodity type services like lab, imaging, and value pricing, or excuse me, on the commodity services, that's really where, for services where quality is thought not to vary. When you move into value pricing, you're actually adding a quality component, and quality can vary. And so as you get to the higher end of that spectrum, that's when quality gets inserted. And again, when you look at the Safeway, when they applied reference pricing to their colonoscopies, and they've now applied it to other procedures, they were able to hold their per capita healthcare spending flat. And I think you'll hear from CalPERS about the savings that they were able to achieve. And I think as we go into what's next for reference pricing, you'll find that reference pricing is going to gain in popularity. Only about 5% deployed this strategy in 2013, but we expect closer to 15% in 2014. That's from a recent Towers Watson and BGH study. I want to go back to this issue of price variation, because one of the things reference price does, like why implement reference pricing? One of the main reasons you do it is to really bring huge spotlight on the price variation and how it is unwarranted. And market power will drive the price, and price is the leading cost of healthcare growth today. And so reference pricing is a way for employers, purchasers, those that we work with, to really say that that price variation is no longer tolerable. What's next for reference pricing? Just a couple of things. Price transparency and quality transparency. As reference pricing grows, in popularity, so will the price and quality transparency tools. They will have to keep pace. The other thing is, the last bullet on here is that we really expect reference pricing to ultimately be paired with bundled payment. And this is important. CPR partnered with HCI3, the Healthcare Incentives Improvement Institute, to write a paper on how, if you pair reference pricing with bundled payment, you actually can move the market and educate consumers along the way. And it's actually a natural fit. Bundled pricing, bundled payment is a package price for lots of procedures within a particular service, let's say a hip or a knee replacement. You see multiple providers in multiple settings. A bundled payment is for all of that. And then if you set a reference price at that, you really are making it very clear what's included in the reference price. The providers are very clear about what's in the bundled payment, and we see that really as the next generation. Once we get a little more experience with pure reference pricing, and as providers get more experience taking bundled payment, I think we'll see a pairing of bundled payment and reference pricing. So with that, I guess I'll turn it back to you, Ed, or to David.
You can give David.
Thank you very much.
Thanks very much, Andrea. We are indeed next going to hear from David Cowling, who's the chief of the Center for Innovation at CalPERS, the California Public Employees Retirement System. You may know that CalPERS does a lot more than you might imagine from the title of its organization. It administers health and retirement benefits for more than 3,000 public schools and agencies and state employers, and covering more than 1.5 million in their retirement system, 1.3 million in health plans. And David's here to tell us about CalPERS' reference pricing program and its impact on healthcare and costs, as Andrea said that he might and promised that he might. Thank you for coming.
Thanks, Ed. I'm going to talk about CalPERS reference. Oh. Who's on?
Okay, sorry.
I'm going to talk about CalPERS reference-based pricing program for hip or knee replacement. As Ed alluded to, CalPERS provides health benefits for about 1.4 million members statewide. That includes active and retired state employees and about 1,200 local agencies, including school districts. About a third of those end up in the preferred provider organization with Anthem of Blue Cross of California. And we spend about $7.5 billion annually in health benefits. And I don't know about in Washington, but in Sacramento, that's a little bit of money. So the impetus for reference-based pricing was a variety of studies, and they all had different purposes, but they ended up kind of helping guide reference-based pricing for hips and knee replacements. The first one looked at cost drivers for CalPERS, and it turned out that osteoarthritis is one of the drivers, and about a third of those osteoarthritis costs come from hip or knee replacements. In addition, a deeper dive showed that from 2005 to 2008, there was about a 40% increase in that cost for hip or knee replacements. One of the other studies we looked at included looking at kind of regional variation in costs. But when we looked at that, we also saw not only those regional cost variations, but also a lot of variation within region. And I'll have some charts to show you that kind of variation towards the end. In addition, we, as Andrea alluded to, a lot of the literature in our in-house studies suggested that the hospital cost had little to do with the clinical quality of hip or knee replacements. And so as you go through the four requirements for reference-based pricing, you have variation of cost driver, potential that volume might increase quality, and then the last one is that the procedures could be scheduled. So in January 1st, 2011, CalPERS, along with Anthem Blue Cross California, implemented the reference-based pricing program for hip and knee replacements. 46 facilities met the quality, cost, and geographic variations. In addition, there was a volume gate in addition to those quality gates. The volume gate included that they that they conducted 10 hip and 10 total hip replacements in the previous 18 months. The value of $30,000 was chosen as the threshold, and I think Dr. Bellman will talk a little bit further about this later today. But about 2/3 of the facilities charged less than that, and included a large number of facilities that were well-known and had a good geographic representation. When we look at the implementation, Anthem did a lot of working with providers and orthopedists on outreach. You know, a lot of times they act as the gate or the steerage of the patients. In addition, a lot of outreach was done with the members themselves. Not only was provided in the brochures and the coverage, evidence coverage kind of materials, but also whenever there was a pre-certification or pre-notification to the patient, that included the reference-based pricing facilities and a description of the program, as well as if there was time between the pre-certification and the actual surgery, Anthem would call up the patient and advise them of the program as well. In parts of Northern California, there's lots of travel needed, and so there's not actual facilities there. So included in this is a travel benefit to the member and their companion. And then the last one is that the one very important part of this is for the reference-based pricing was only for routine procedures. Any non-routine procedures would have a medical exemption. So I'm going to talk about the evaluation results of the program, and these results are mainly from a study that we did with UC Berkeley, Jamie Robinson and Tim Brown, which was published in Health Affairs in August of this year, and that I think is in your packet. So this is looking at utilization. This is the volume of hip or knee replacements, and the first 3 lines in this chart have to do with CalPERS Anthem enrollees, but what's unique about their study was they were able to get from Anthem the non-CalPERS enrollee data as well. And so we can look at where our members were going before and after the implementation of the program. And so the first line is the volume, the number of procedures, and then the second line is looking at what percentage of our members went to the reference-based pricing facilities. And we can see that it was about 50% or so before the implementation of the program, and then there was an increase up to about 63-64% afterwards. If you look at the non-CalPERS members, it was about 55% before the program to the reference-based pricing facilities, and it slightly dipped and then came back. And I have a visual representation of that next. The dark blue line being the CalPERS reference-based pricing usage. You can see it went up dramatically after the implementation of the program, and we can see for the non-CalPERS it was fairly the same over time. So this is a chart or a table of the average prices charges for hip or knee replacement surgery, again for CalPERS members and non-CalPERS members. And so the first line here is for average of all facilities, and we can see that basically for all of the, across all the groups, that there was an increase from 2008 to 2010. And the average was about $35,000 in 2010 for the CalPERS members, and then after the implementation of this program, it dropped around $25,000, $26,000 in that range. What's really interesting is that the reference-based pricing facility costs stayed the same from 2010 to 2011, 2012, virtually the same. What was surprising was this impact in the non-reference-based pricing facilities, which went from around $43,000 and dropped dramatically down to $28,000, $27,000 after the implementation of the program. So by having a comparison with the non-CalPERS Anthem group, we can see that for most of the part, those charges stayed the same outside of CalPERS. And again, I have a little chart showing that. So the solid blue line is the CalPERS reference-based pricing facilities, which is pretty stable over time. And then we see the implementation of the program, which is the dotted blue line, and you see this dramatic drop in prices. I have one more chart, kind of which getting at what Andrea was talking about with the variation in cost. And I don't know if they show up as pink dots here or orange, but they were pink originally, or orange originally. I think they're pink now. But the reference-based pricing facilities that the blue dots are for the reference-based pricing facilities who are participating in the program, and the pink dots are the charges for the non-reference-based pricing facilities. And so what we see is that in 2008, 2009, 2010, a lot of variation, with the pink dots kind of clustering around 45,000 in 2008, going up in 2009, and about 50,000, a little clustered there in 2010. And then after the implementation of the program, the pink dots now start clustering around the $30,000. So we reduced variation on the high end. The bottom end of the cost for procedure stayed pretty much the same. So jumping to the results and conclusions, Jamie Robinson at UC Berkeley concluded that there was about $5.5 million savings over the first 2 years. This resulted in an average cost decrease of about $9,000 per procedure, or 26% drop in cost for us as CalPERS. Also important to note is that the clinical quality, and Dr. Bellman will talk about this in a little while, about the study they did, but the clinical qualities got better or stayed the same for CalPERS, or for the reference-based people who went to the reference-based pricing facilities. So this turned out to be a hospital market story as much as a consumer enrollee story. Reference-based pricing induced enrollees to go to the reference-based pricing facilities, but also it really changed the market as well. Jamie Robinson concluded about 14% of the savings were due to market share, and about 86% were due to the reduction in prices. So another important thing is that it's working in the market as well. We've expanded the program from 46 hospitals at the beginning in 2011 to 61 now. And so we've expanded reference pricing, and as Andrea alluded to earlier, that we have these low volume, high cost for hip and knee replacements, and we've moved in 2012, we moved to this kind of more high volume, low cost procedures, looking at cataracts, colonoscopies, and arthroscopy in 2012, and we're in the middle of evaluating how that's working. And again, I would reiterate that those 3 procedures meet our kind of checklist, which was the cost variation within region, a focus on volume increase may increase quality, they can be scheduled, they are substantial cost to us. And the last thing is we have a variety of initiatives around educating the consumer and kind of the price transparency, trying to get that information across, and we're moving forward with that. Thank you for hearing our story today.
Great, thank you very much, David. If we can reposition the clicker. We're going to hear next from Teresa Monti. She's the Vice President of, and this is very impressive, Total Corporate Awards at the Kroger Company, which most of you know is a Cincinnati-based corporation that's the country's largest grocery store chain. It's actually the 4th largest retailer of any kind in the world. And Teresa's in charge of Kroger's health, welfare, retirement, and pay plans. Pretty broad portfolio, and Kroger's had some experience with reference pricing as well, as you've heard, experience we've asked her to share with us. Teresa?
Thank you, Ed, and thank you for coming today. I just wanted to spend a little bit of time talking about what we're doing around reference-based pricing. We happen to call it target pricing because we thought our associates might relate to that a little better. So I might refer to it at target pricing throughout my discussion today. But I wanted to start just by giving you a little bit of information about the Kroger Company so that you can get a flavor for what we're all about and where we focus our efforts. We employ about 343,000 associates, all U.S.-based. We operate in about 35 states across the country. In the company healthcare plan, we have about 85,000 eligible associates. The rest of our associates are represented under collective bargaining agreements, and their benefit plans are provided through Taft-Hartley Health and Welfare Funds. So where we innovate and where we try new things are really within the company plan, and that's where the target pricing initiative is today. So that's where I'll focus our discussion for this afternoon. Mainly, we operate grocery retail centers throughout the country, but we also have distribution centers, fuel centers, manufacturing centers, fine jewelry stores. Usually I get a few eyebrows that raise when I say jewelry stores, but we are one of the larger jewelry chains in the country as well. To talk a little bit about what our objectives are within our healthcare plan, we really focus on trying to keep it simple for 350,000 people to try and understand what we're trying to accomplish with the healthcare benefits that we provide to them. We really focus on two objectives. The first one is to improve the health of our associates and their family members. We truly believe that if we can improve the health of our associates and their family members, not only will we be able to hold down costs for the company and costs for our associates, we also think that's a better place to be as an organization, right? More productive associates, happier work-life balance. So we're very focused on health improvement. And then secondly, we're very focused on reducing costs. The grocery business is not one of high margins, so we're very focused on where we invest our dollars. We spend about $1.5 billion on healthcare for all of our associates in all of the benefit plans. So we're very focused on health and reducing costs. And as we're looking at ways to reduce cost, we're constantly looking at not just what healthcare costs, but how people access the healthcare system and where they're choosing to get care. So where are they making or where are they able to make decisions around quality and cost as they're accessing healthcare when they need it. So a couple of initiatives. I'm going to focus most of my discussion today on our target pricing initiative, but when we implemented that in 2012, we took two initiatives at the same time and focused on target pricing, which is our discussion today about putting a price in place for certain services, and we focused our services on high-tech imaging, so CAT scans and MRIs and the like. We also, at the same time, put in a very specific Centers of Excellence program to focus on knee and hip replacements and spinal fusion surgeries. So that particular initiative, which I have just one or two slides at the end, is really focused on quality of care and cost of care. Target pricing, as my other panelists today have talked about, is not so much about quality, because we're assuming that the majority of the quality in a high-tech imaging service is relatively the same. The difference is in the variation in cost. So our two different initiatives are addressing both cost and then on the Centers of Excellence piece around quality of care. Our target pricing program, we partnered with Anthem. Anthem Blue Cross and Blue Shield, or WellPoint, is our claims administrator for our self-insured plan. So they were very instrumental in helping us design our target pricing and our Centers of Excellence program. But the target pricing program really has three levels where associates and providers get involved in making the choice about where to access a high-tech imaging service. So the first thing that we put in place is that any high-tech imaging service has to get prior authorization or pre-certification. So the provider or our associate would call Anthem Blue Cross and Blue Shield before a service is received, and that is where it really starts. And so on the slide here, you can see the AIM, or high-tech imaging. That is usually where a physician or a provider would get some education about our target pricing program to help them understand that the plan has a certain threshold of how much we will pay for high-tech imaging services, and help the provider then understand where in the market can they go, or where they can send their patient to stay at or below the target price. So that is the first level, and you'll see in some of the results, that's usually where most of the services will get redirected then. The second part, we call it the shopper program, and that's usually where a nurse from Anthem will outreach to our associate or their family member who's due to get an MRI or a CT scan, and help them be more educated on our target pricing program, to let them know that the plan will pay up to a certain level, and that there are a lot of choices in their market to help them understand what providers they can go to if they want to pay at or below the target price, or if they choose to pay more and go someplace else, that they can do that as well. So completely voluntary program, but we do help to educate both the provider and our associate as they're making the choices of where to go to get their care. And then the third piece is actually implementing that target price. So in 2012, we started with 5 high-tech imaging services And we started only in 10 anthem states. So it was technically a little pilot for us and in terms of how we implemented it. So you'll see here on this slide, five tests in 2012. We added a 6th high-tech imaging service in 2013. And also in 2013, we expanded it to all of the US states across the country. So we were able to capture a lot more of our associates in that initiative. So a little bit about the results that we're seeing. You can see here from the 3 levels of the program, the clinical review operational activities, so that's the first level where most of the services are getting redirected to a provider who is at or below the target price. You'll see the 2012 total year savings, and remember that's just 10 states for us, and then the third quarter 2012 year-to-date, or 2013 year-to-date savings, slightly bigger, but again, across the entire US. The middle, the shopper program, not as much savings, but we wouldn't expect as much there. We'd hope that most of the services would get redirected, and they have, prior to getting the outreach call from a nurse to an associate. And then actually implementing the threshold of the target pricing program. We have about 30% of our population that still chooses to go over the target price, and we think that really comes down to education. So if you think about a lot of people when they go to the doctor still aren't comfortable questioning cost or questioning quality, questioning where their doctor sends them for a service. So we still have, again, about 30% of the population that chooses to still go to a facility that is at or above the target price. To give you an example of the variation in cost, in Ohio, for a CT scan of the abdomen, the costs range from about $260 to about $2,600, depending on where you go. So that education alone, both to the provider and to the associate, to our associate, is critical. Right now, it's all telephonic based, and so getting them to really have that conversation with their provider is difficult, but we are making progress, as you can see in our numbers, and really getting people educated. Early in 14, we'll be implementing an online tool so that people can access cost and quality transparency, cost information online so that they can start to make even better decisions. So what we actually saw with unit cost, when the blue rows here are the 2012 results for the 10 states where we had target pricing in 2012. And as you can see, we were actually able to reduce the unit cost through target pricing by redirecting people to a cost-efficient provider by about 12% on both CT scans and MRIs. Compared to all other states in 2012 where we didn't have target pricing implemented, costs actually increased for both CT scans and MRIs in 2012. When you break that down by the 5 services, high-tech imaging services that we had in 2012, you can see each of the individual services in the 10 states where we had target pricing in 2012. All of those went down, some of them significantly. So if you look at the abdomen CT right there in the middle of the blue section, went down by 32% in unit price in the states where we had target pricing, compared to some of the increases in the other states for those same services. So at the same time we implemented target pricing for medical services, the high-tech imaging, we also implemented it on several prescription drug categories. So I wanted to give you just a little bit of the results from the prescription drug side as well. Kroger has our own PBM, so we use Kroger prescription plans to help us design a very similar target pricing initiative that we had in the medical world, in the pharmacy world as well. And so we took 3 categories of drugs in 2012, and that's the statins, the PPIs, and the blood glucose test strips. In 2013, we added the ARB category. And that really focuses on education at the point of sale. So when someone is in our store, they're at a pharmacy and they're talking to a pharmacy tech or a pharmacist, really being able to get that education about the choices that they have to make. Because if you think about some of the drug categories, statins as an example, huge variation in cost. And we're just starting to see that drug category kind of settle out a little bit with Lipitor going generic last year. But there's a huge variation in cost and not a high variation in effectiveness in that drug category. So we've seen some really great results on the pharmacy side as well. And here is just some statistics on what we saw in unit cost in the prescription drug side. So you can see some pretty significant cost reductions on all three of the drug categories in 2012. And utilization was not significantly impacted. I think initially what some people might think is that individuals might forego a medication because of target pricing, because some of that cost may end up with them if they choose a higher cost drug. We saw a little bit of that in statin category, but other than that, the utilization, or I'm sorry, in the PPIs and the test strips, the utilization went down a little bit, but not significantly. And we're really watching that closely, because what we don't want to happen is we don't want people to stop taking medications when they need it, but we just want them to be better educated about the cost and the quality of the services that they're receiving. So just a brief moment on Centers of Excellence, and this is the service. What we did is we looked at knee replacements, hip replacements, and spinal fusion surgeries. Musculoskeletal conditions for us has always been one of our highest categories of spend in our medical plan. And so we looked at how could we look at cost and look at quality of care that people were receiving. And could we take a network and tier it so that we could pay just a little bit more and include travel expenses if someone was willing to go to a high-quality, cost-efficient provider for a particular joint replacement or spinal fusion surgery. And so we were able to do that. We actually have 4 tiers within the network, and we leveraged the Blue Cross and Blue Shield Centers of Excellence, or Blue Distinction Network, and we tiered it even further. We started with quality, and we added a cost component. So this is some of the results from 2012 and 2013 when we implemented that. So we had about 264 joint replacements or back fusion surgeries in the last 18 months or so. In the middle blue bar, you can see the impact to the cost of someone who chose to go to the highest quality, most cost-efficient providers around the country. We saw about a 28 to 30% reduction in cost. When you include travel, so we paid for travel and a companion to travel, very similar as to what CalPERS is doing. Again, about a 30% decrease in cost. And from a quality perspective, no adverse side effects. Potentially avoidable complications, there were none in the first year by someone going to a facility that may not be in their hometown, where they had to travel for that knee replacement. In the first year in 2012, we had about 20 facilities in the network. So we had people traveling around the country for those surgeries and had really great feedback and great experiences. And as you can see, great quality and low cost for our members or for our associates. And overall, I would say our associates are very pleased with the programs. One of the things we thought we would hear, especially on target pricing when we implemented it, is a lot of pushback. You know, you're just shifting the cost to me. And instead, what we're hearing is thank yous. You know, thank you for letting me know that there's such a big difference in cost in my community. And if I know I can go someplace else and get the same quality at a less cost, that's good for them and it's good for the company. And so we're actually seeing a lot of positive results and a lot of positive feedback from our associates by doing things like target pricing and centers of excellence. So thank you for your time today.
Well, thank you, Teresa. Very interesting stuff. And finally, we're going to hear from Dr. Michael Bellman. He's the Regional Vice President and Medical Director for Programs and Innovations for Anthem Blue Cross of California. Anthem, as you've heard, is a part of WellPoint. He's been trained as an internist, specialized in pulmonary medicine. He's been with Anthem since '96, and he's in a great position to discuss with us the role of insurers in reference pricing and their various partnerships with employers. And by the way, Dr. Bellman made a couple of changes in the slide pack from the version you have in your kits. So you'll be able to get the latest version on the Alliance website after you get out of here. Dr. Bellman, please.
Well, thank you, Ed. It's a pleasure to be here, and thank you for coming. I wanted to start with a personal story because it's relatively recent that I think pricing has become such a big topic. Previously, it was very much hidden and very much undercover. So my own personal experience is that I'm going to release some personal health information here. I had cataract surgery 4 years ago and 2 years ago in Los Angeles, and used for the first surgery a innovation on our Anthem website, which provided the total cost of various procedures. That was the total cost that would include the facility, the physician, the anesthesiologist, the lens, etc., whatever you need for a cataract. And what I learned is that there was a wide variation in the cost. I live in West Los Angeles, where it's not only important to look healthy, you have to look good as well. So one of the striking features was that a freestanding surgical center in 90210, just around the corner from the Gucci store, in fact, was a total price of $3,500 for the cataract, whereas the two largest West Los Angeles facilities, one an academic institution and the other a very large community hospital, the academic institution was about $6,000, the large community hospital was $11,000. For me, as an individual who paid a 20% co-insurance, the benefit was direct to me in the sense that the co-insurance on the $3,500 saved me $2,000 to $3,000 out of pocket as a result of that, and it also saved Anthem money in the sense that they paid the $3,500 and not the expanded fee. So I'm telling you this because my experience, although it was relevant for me, didn't make much of a dent in these two high-priced institutions, and it didn't save that much money for Anthem. But now what we're seeing unfolding and what you've heard today from Kroger and from CalPERS is the realization or the actualization of these differences that make a big impact in terms of the price that everybody pays. Because, in fact, once these expenditures from these employers starts trending down, and in some cases it is trending down, that makes a difference to the premiums that they charge the following year, and that's the premiums that you pay. So this is a direct impact for all of us. So I just wanted to emphasize that because it obviously has relevance. I'm also using my iPad because as good as the cataract surgery was, there is no way that I can read that screen over there. So the point that I wanted to make at the beginning is that the costs outside of premiums, co-pays, and deductibles are typically unknown to the average consumer, and I might say also to the average physician. And that's why this is an education for physicians, and I commend Kroger, in fact, on making sure that the physicians know about that, because physicians are totally oblivious to what the charges are. They know what they receive, but they do not know what facilities receive, what drugs cost, etc. And in fact, a recent article in the New England Journal of Medicine highlighted this dilemma and actually called the co-insurance and deductibles an avoidable side effect of treatment or harmful effect. In other words, people undergo treatments and or receive medications and then have the unpleasantness of finding that the charges that result or their out-of-pocket expenses are so extreme as to make it extremely difficult to actually pay for these. So this becomes very relevant in this setting. So we also know that in California, the hip and knee replacements varied between $20,000 to $110,000 across the network. So you saw a similar diagram to this where we talked we had the talk from CPR. And essentially, this shows the range of pricing in California of the 110 or so institutions that provide hip and knee surgery. So it was noted that when you choose a value of $30,000, that you encompass a significant number of institutions within the network. It also included a wide geographic distribution, so if there was travel involved, it was a reasonable amount of travel and didn't require long distances. And this was really, I think, the basis for the number. The other point that I think was important is that we did look at am I going the right way? I'm going the wrong way. There we go. We did look at the quality, and I'm going to come to that in a moment, but essentially, the value-based purchasing design establishes the payment threshold for elective procedures. It limits the obligation of the payer and guarantees members the ability to choose a facility that will provide services within an appropriate cost range. One interesting term that has been used is it acts as a reverse deductible. Instead of the enrollee paying up to a defined limit and then the plan taking over, which is the standard deductible that many of you are familiar with, in this case, it turns that on its head and the plan pays up to the limit, after which, if the enrollee chooses an institution above the threshold, the enrollee is liable for the increment. The participating hospitals were based on the procedure volume, as you heard. They met the standard regulatory standards, so they were all accredited at high levels by the appropriate external agencies. And we also have an Anthem quality program for hospitals, and a number of metrics are measured across a broad range of procedures and tests and treatments that the hospital provides and outcomes that they report publicly, and it's combined into a score. All of these hospitals were participants in the Anthem program. So the overall impact was the shift of members to designated hospitals and shift away from non-designated hospitals. And I think it would be appropriate to re-emphasize that point, that although there was a shift to the designated hospitals, the big change was the shift away. And the decrease in total costs, and this I think was a critical point, that how the market reacted to this, was the decrease in costs in the non-designated hospitals, some of which immediately prior to the advent of the program, lowered their price in order to be part of the network. The other point that is made in the article by Jamie Robinson in Health Affairs is that the upward cost trend from 2008 to 2010, which went from 28,600 to 34,700, was reversed in 2011 with the advent of this program. So this really was a very striking example of bending the cost curve down, which I believe is the Washington phrase for, or the goal that has been set for the Affordable Care Act. On the quality side, we used the hospital claims to look for general complications and general infections, things that are not related necessarily to the surgery itself, but if there were results, let's say, from heart problems, lung problems, kidney problems as a result of the surgery, or that there were infections like pneumonia or kidney infections and so on after the surgery. And in fact, in the designated hospitals, these rates actually dropped slightly, significantly, but they dropped. There was no difference in complications related to the surgical site itself in terms of the prostheses that are placed, the hips or the knees. There's no difference between the two sets, and no other site-specific complications like local infections or bleeding and the like. We also followed the claims for 180 days after the surgery, and it's important to note that there was no difference in the readmissions either for joint issues or for other complications in the two populations that went to the two different institutions. And also bearing in mind again, and I should have maybe emphasized this, we're also comparing it to non-CalPERS PPO Anthem members whose claims we also had. So as you saw in some of the slides that were shown earlier, there was this comparison group of Anthem PPO members in the same geography as were the CalPERS members. We have a number of other clients that have, as a result of the successful experience we had with CalPERS and with Kroger, have also joined the reference-based benefit movement, and so I've listed some of these. It's not as important as much as the fact that there is now, I would say, a shift, and a number of large employers are embracing this program as a way to disrupt the continued increase in healthcare costs, very largely driven, in fact, by institutional pricing. So this has been a very encouraging development. In addition, we also have expanded it to include what Kroger has included and what others have used in the past to include it for outpatient procedures, which are for cataracts, arthroscopy, and endoscopy. So this is definitely something which has really blown the lid off, I think, the veil of secrecy over pricing, together with a number of other events that have happened in the past in some recent publications, including the very notorious one in Time magazine earlier in the year, which I think was also a major impact, as was CMS's actually release of Charge Masters, which occurred recently as well. Should also just mention, because I noted in the Wall Street Journal, which was left outside my hotel room this morning, an article from the Intermountain health system run by a very, very prominent health researcher, Brent James, on their current initiatives within the Salt Lake City region, and I would imagine most of Utah, to develop not what they call a charge master, but in fact a cost master, where they're actually developing costs of procedures based on real data, not wishful thinking and numbers sucked from thin air, which has been the basis of most charge masters up till now. And I think this is really the start of a new movement where cost accounting, which has been a part of most other industries, will, I think, enter the healthcare arena and make it much more logical and much more sane. So that I thought was an encouraging development. So in summary then, our reference-based pricing of the benefits expands the transparency of medical prices. It raises the question of wide variation in price for the same procedure is justified. It is important to document that quality is not reduced, and there are a large number of organizations that are out there collecting quality, but there is still much work to be done in this regard. It provides a useful means of helping purchasers and members make choices that help reduce costs, both for the company, for the individual, and it's definitely a valuable tool in the overall approach to bend the cost curve down. So, thank you.
Terrific. Thanks very much, Michael. We are at the point where you can have input here. There are green cards that you can fill out a question to ask one or more of the panelists, and there are microphones that you can use to vocalize your questions, and I would invite our panelists as well, if you have comments about anything you've heard, or if you wanted to ask one of your panelists another question, to jump right in and let's mix it up. And in the meantime, the first mixer-upper, would you please identify yourself and keep the question as brief as you can?
I will do both. I'm Bill Rogers. I'm confident in the statement that there's no such thing as a stupid question. My first question is, do all of these reference prices include the professional or physician's payment? And then my second question is, how do you all decide what to do in subsequent years with your reference price?
Two good questions.
Well, the answer to the first one is yes. It was the total claims, institutional and professional, that were included in the calculation.
And Andrea, you talked about bundled payment being a part of this calculation.
Right, so I think in the CalPERS example, that's one. Not all reference pricing programs include both. So that's something you need to distinguish. But if you, as this evolves and as reference pricing gets paired with a bundled payment, then yes, you'll see them be bundled together and paired together.
So if I could just make one additional comment, which when you look at physician reimbursement across the state, and I'm referring now to Anthem's reimbursement, there is variation geographically minor, and in some cases, if there is special expertise. But the degree of variation or the standard deviation of the reimbursement is a fraction of what it is for facilities.
And how about adjustments? Those of you who are involved in this business, how do you go from year to year? Can you ratchet down further, or do you have to take into account what's going on in the market?
Well, from Kroger's perspective, we looked at it on the 5 services that we target priced in 12. We did look at the cost data for 2013. We decided to leave the target price where it is, and it's roughly around $800 for one of those high-tech imaging services. But we found we didn't really need to adjust it at this point. But our plan is to look at it every year, because what we don't want to happen is our target price stays the same, but the cost of services continues to go up. So we need to adjust that, and we will as we need to as we move forward. But our hope is that it brings down the cost and that we have more and more people staying at or below that target price wherever we can.
Okay. Yes, ma'am.
Hi, Sandra Wilkness from Senator Heinrich's office. I believe it was mentioned that education was the variable that was distinguishing between those who are opting for reference or target-based procedure or facility and those that weren't. And I'm wondering if there's any evidence of that or evidence of any other variables that would distinguish between folks who do and don't, and also providers who opt for that and don't. Thank you.
Well, I'll talk about it from Kroger's perspective. We have Anthem after every individual that does have an MRI or that's going through our target price program. They're actually surveying them and asking them a series of questions. Did you know about the program before you had the service? Do you understand how it works? And what we're finding is that there's a vast majority of people that just didn't understand it. So I think there is a big education component, getting people to understand, one, what their benefits are, because it's complicated. You know, they understand deductible and coinsurance, and anything past that, they don't. It's complicated. So having that initial education up front, we do a lot to communicate to our associates on their benefit plans and give them access to a lot of resources. But it's going to take some time, I think, to really get people to understand that they do have choices to make and that there is a lot of variation for certain services in the healthcare system. So we're going to continue to educate and continue to give them access to resources. I also mentioned, I think, that right now we don't have an online tool where people can go to get information about cost and quality of providers in their community, and we will be implementing something like that in the first quarter of 2014 so that they can access information before they go to the providers and before they have to get a particular service. So we're hoping that will help further educate people.
David?
And pretty similar to CalPERS situation as well in terms of Anthem does a patient experience follow-up study and looking at members' knowledge of the program and all of the follow-up questions and their awareness. And so it's similar to Kroger. We're rolling out in mid-2014 a much more web-based and mobile tool to provide cost and quality information as well.
Okay, well, you've unleashed a tremendous volume of questions on green cards, and we're going to plow right in. A lot of them are very basic, and I think will help fill in some of the blanks in people's knowledge. How do insurers handle complications in procedures that extend the cost above the reference price, and are consumers forced to accept that burden?
Right, so the reference price is for routine procedures, and so if the procedure starts off as routine and becomes non-routine, then it would not fall under the reference-based pricing program. And I think you see that when I was showing some of the variation in the chart. You'll see some of those dots are outside of the 30,000 or above that, and those are falling into the non-routine procedures, which are not excluded from the way that the claims data is set up.
Before, don't forget what you were going to say, but I did want to follow up because there's another question in the pile that asks about how you work that medical exception. Does it happen before or after? How big is the division between the two categories? That sort of thing. Say a few more words.
Dr. Wildman might know more of the exact details, but my understanding is that it works through, it's before, and it would also occur after if, say, a colonoscopy gets in and they need to do some other procedure.
Right. No, it's a question of communication between our case manager and the CalPERS staff so that the aberrations or the exceptions are picked up and then can be dealt with.
Okay. Andrea?
I was just going to say that, so when it falls into the exception and outside of the reference price, the normal cost sharing would apply. So just to round out the story, that if you're outside of the reference price, meaning you're an exception to the rule that would qualify you for it, then your normal cost sharing and your benefit applies.
And could I, actually, one of the questions that came in before ties into that, that line of observation, and that is, you're talking about major procedures with potentially thousands of dollars, even in the copays. How do these potentially large out-of-pocket expenses square with the out-of-pocket limits that are supposed to go into effect in the Affordable Care Act next year, which I think are something like $6,400 a person per year? Or has no one thought of...
My impression is that at present, this particular program, where there are options to go to a reference-based a facility that is designated within the reference price range, is not the same as the standard open-ended out of pocket when you go to any number of institutions. So there is the choice that the member has here to make to stay within the range of the expenses. That's my understanding. That's the current perception.
And can I rephrase that? That means if the patient chooses a non-participating program that doesn't meet the price point, whatever that excess is does not count toward the whatever $100 out-of-pocket limit in the ACA? Is that a fair reading of what you just said? And
That's
is
my
that the
understanding.
case? Okay.
That's my understanding as well. I think we have some, I think there's some resolved interpretations, because one of the things as representing purchasers, purchasers work with many health plans around the country, and not all health plans are equipped or able to or want to implement these kinds of programs. So I think there are different interpretations around that particular issue, which, you know, is maybe health plan dependent. It could be other variables about why someone won't implement it, unlike WellPoint that has decided that it's viable.
Another question about prices. How do you monitor whether the prices rise for the non-reference price procedures? That is to say, is there some sort of cost shift going on?
Well, I'm sorry to.
Go right ahead.
I will jump right in and say, so one of the things when CPR has been advocating for reference pricing, or at least encouraging our purchasers to use it as a strategy, the criticism is, well, that's, as I said before, it's a really blunt instrument to use in the marketplace, and you just whack at it, and now you've disrupted the market. But the reality is that, you know, employers do have to kind of stand up and say, you know, we're not going to tolerate the variation anymore. And, you know, I think when you send that message into the marketplace, they're going to respond with a shift in volume, and when there's a shift in volume, then you see a change in behavior.
And sort of a variation of that same question has to do with the impact on physician incomes. Has there been pushback from physicians on this aspect because the total amount is lower than it would have been otherwise, or volume isn't flowing to the hospitals where they have privileges? Have you heard anything like that?
I can't
What?
speak to that.
No?
I think anecdotally, the orthopedic surgeons have all been pretty positive in terms of coming forth, in terms of the participation program. As was mentioned earlier, the variation in cost has little to do with the professional fees that we see. So there's a little less, you know, pushback from that.
Okay.
Yeah. Just the one point I would make, I think it's logical to assume there's going to be disruptions, and that's clearly the part of the goal of these innovations, is to reduce the cost trend. And a number of stakeholders will get impacted through various interventions. This one happens to possibly impact physicians to some extent and facilities, but there are others that impact individuals, plans, and so on. So I think we're all in this together, that we're searching for ways to come to, you know, reasonable adjustments to this fact that the trend has to come down. But it does raise the issue, both with bundled pricing and with reference-based benefits, that in this case, we assume that the physician's decision to operate is correct and the procedure gets done. So there is no second guessing here to say, well, maybe you didn't even have to do it. So it's all very well to have reference-based benefits or bundled prices, but you can make it up on the volume. And so everybody, and so the physicians would certainly come out equal in that setting. So it's encouraging to see that some of the quality metrics that are being developed, and there are registries now being developed around the country. There's one in California, the California Joint Replacement Registry, which is collecting data on pre-operative and post-operative enrollee function, pain, etc., so that these indices can be incorporated into the decision-making process. So when the surgery is decided upon, it's based on some rational information, and there's tracking of provider performance in each of these metrics.
And of course, the Kroger program has a pre-authorization.
We do, and I think the disruption is exactly why we're doing what we're doing. We want people to understand that there is a variation in cost that isn't necessary. And so the more that we have providers calling Anthem questioning why the flow or the volume is going a different direction is great. That's exactly what we want to happen.
Andrea?
Yeah, I was just going to follow up on a point that Dr. Bellman made, which is, there is a risk of the payments being made up for on other services. But I think if you sit across from a hospital CFO, they will say, well, I know what my margins have to be. I know that if I'm going to take a hit over here, a haircut over here, I'm going to have to increase something somewhere else, whether it's on price or utilization or volume. And I think there is the risk of that happening. I don't know that we have any evidence of that sort of shell game actually happening. I think the insurers, once they have a little more experience with reference pricing, and as they see how charges, if they have their payment tied to charges and those change, then they will, will have a little more evidence of whether there is that kind of cost shifting within a facility's procedures. But I think while it can happen, it should not limit the first step, which is to implement the reference pricing on the front end.
Yes, David?
Yeah, we get the same question as well for the hips and knees, kind of looping back around. And as you saw in our numbers, we didn't actually see an increase in volume over the time. And then on the other 3 procedures that we're looking at, I think we've seen a little bit of increase in colonoscopy, but that necessarily isn't a bad thing. That's for screening like that, it's probably a good thing.
Okay, yes, ma'am.
My name is Lisa Summers. I'm with Centering Healthcare Institute. And my question is for Andrea or anyone else on the panel, but particularly given CPR's work on maternity care payment reform. Certainly, OB care is not entirely elective once you're pregnant. You have to deliver, but women certainly have months to shop for prenatal care and delivery services, and we know there's huge variation in cost and quality, and it's a very high frequency occurrence with 4 million births a year. So I'm interested in whether or not any of you are looking at reference pricing for maternity care, and if you have thoughts about whether or not the lessons we've learned from the global payment in maternity care, which is somewhat like bundled payment, informs this discussion at all.
So I'll start by saying that so far, I think while we work with some very progressive employers, they sort of self-select to be that way by being part of Catalyst for Payment Reform. I don't know that maternity care services will be at, that's probably farther down the road in terms of reference pricing. I think maternity care is much better suited for bundled payment or a blended payment methodology, because you have so many parts of you do have time to look around and shop, but you also have many providers within that system. And then once you're in the facility delivering, there are other variables that can come into play. So I'm not sure that we'll see reference or maternity care be a reference priceable, if that's a word, benefit. It may be, but I haven't seen it yet. I think it's more appropriate for different kinds of payment reform, like bundled payment or blended payment.
The one comment I would make is that you're right that there is wide variation. We haven't looked at bundled or reference-based pricing, but because of the wide variation in, for example, C-section rates amongst hospitals, which in California range from 22 to 50%, and the appearance or the fact that there is now a decreasing, but until now, a fair number of women who were induced, where labor was induced prior to the 37th week, or just shortly after the 37th week, between 37 and 39 weeks, which is now recognized as actually a contraindication. If there are no other complications, term should be 39 plus. And the rate of these non-medically indicated premature deliveries has gone down dramatically, but that particular target plus the C-section rate, if those are reduced, can reduce costs here enormously, because a large number of those infants end up in the neonatal intensive care unit where costs are astronomical. So one of the early successes we've had is with, in fact, with reducing C-sections and with reducing premature induction of labor where it's not indicated, and reducing admissions to the NICU. So that can have a big impact on total costs and out-of-pocket costs for people.
I'm sorry, this is actually an area where the private sector can learn from Medicaid, because we have several state Medicaids, and we just released a case study on South Carolina's birth outcome initiatives, where it's not a reference pricing program, but it is a non-payment policy for early elective inductions. And so the commercial private sector could learn a lot to reduce those C-section rates and the early elective inductions, which are a major cost driver.
Good point. Yes, go right ahead.
Hi, my name is Sabiha Zainalbai. I'm from the National Academy of Social Insurance, and I have two short questions. So in addition to consumer education, are there a new set of challenges for implementing reference pricing for orthopedic and other healthcare services versus implementing it for drugs and pharmaceuticals? And then really quickly, my second question, are there examples from either at home or abroad where reference pricing has not worked in bringing down either the cost of care or in bringing down the quality?
I think reference-based pricing, target pricing is still so new that it's hard to say, where it hasn't worked, right? We're all kind of in that version 1 type of initiative where we're just trying certain things. We're trying different things between CalPERS and what Kroger's doing and what other employers are doing. So I think it's a little early still to tell where it's not working. I think in Kroger's results, we've seen positive results both on the quality cost side and from feedback from our associates. So we haven't seen any one of the things either on the pharmacy side or the medical side where it's not working yet. But we're certainly watching things like adherence rates on the pharmacy side, because like I said before, we don't want people to forego medication when they need it because of cost. So we need to look at that very closely and make sure that's not happening. But right now, we haven't seen anything negative or something that's not working yet.
In our research, we haven't found anything either at home or abroad. I think at home, it is too new. Abroad, where reference pricing on drugs has been quite common, I haven't read anything that would indicate that there was a decrease in, or that it didn't decrease costs, and it also decreased quality, which we want to improve quality. And on the consumer education piece, I don't know if anyone on the panel can answer that question. I don't know that there are different challenges for implementing different types of reference pricing programs. So it's obviously when you're implementing a reference pricing program for hip and knee replacement, which is far more complex than just a lab test or imaging, there are lots of variables in there. The consumer education piece has to be tailored to the type of service, or if you're doing multiple services, it has to be tailored to it. I don't know, I think a lot of it's around medical literacy and being able to articulate something in an easy to understand way, whether it is your lab or a knee or hip replacement, but it's highly dependent on the type of service.
I think the other thing is it's easier to know or to ask about a cost of a prescription drug than it is to know about a cost of a medical service. So when you're going to the counter at a pharmacy, you can ask about different costs for different levels or categories of drugs, a generic versus a brand name, et cetera. It's not so easy on the medical side. You have to do a lot of digging and a lot of research to even know where to go to get cost information on the medical side. So it's a little easier on the pharmacy side today, but we're hoping on the medical side it gets to be just as easy so that people can make better choices.
A couple of times in the last few minutes, we've talked about elective versus non-elective health expenditures, and we have a specific question asking if we have some sense of what share of healthcare spending is elective as opposed to trying to negotiate while you're in the ambulance on the way to the emergency room.
I don't know the proportion of spending.
I don't know it either.
Could find out.
Could find it, but I don't have.
Yeah.
And since chronic care accounts for such a large percentage of spending, particularly in Medicare, does that count as elective or not? One would think that if you're taking a preventive drug or going through some sort of service to keep you from worsening in your diabetes, that would not necessarily be elective.
Well,
And could you apply that, apply reference pricing to those kinds of things as well?
So in the Kroger program, on the pharmacy side, it's any script in those 4 categories of drugs. On the medical side with the high-tech imaging, we don't do target pricing for children. Although we're finding that what's happening with our associates and their family members who are over the age of 18, they're starting to ask questions when their children need an imaging service. So that's good. And we're also not doing it on emergent services. So we don't really call it elective, right? So if you're getting an MRI or a CT scan and it's not an emergency, target pricing is going to apply.
Okay, David, do you have something to add on that? Several people are interested in the application of your travel reimbursement policy. You might call it domestic tourism, medical tourism, yes. So let me just read them off because there are a bunch of different aspects of it. If somebody had to travel to a distant hospital or travel expenses paid before travel in the event the patient can't afford it, what kinds of expenses are covered, such as lost wages for extra time off, child care, post-procedure follow-up visits, expenses for a traveling companion? I think we may have heard a little bit about that. That's all on one question card. Do you pay for follow-up care for patient and family after a procedure at a preferred provider who's located far away from the patient's home? And finally, reimbursement for travel expenses is good, but what about for conditions where travel is difficult and painful, or people who don't have a companion to travel with them? What are the conditions under which you're requiring people to pay for travel impacting their mobility and ability to get to the high-quality care? Lots of interest. Would you like to expand on your descriptions of the travel policies?
Sure. So in the Kroger program, in our Centers of Excellence program, if someone chooses to travel to use one of our, we call them Tier 1 facilities, and they don't have one in their community, we have a group of professionals at Anthem that's what they do. They help to coordinate the flights, the hotels, the meals, the companion traveling with them. All of that is taken care of so that it's not coming out of the pocket of the associate. So it's billed as a claim through our billing process that we have with Anthem. So all of that is taken care of for them. If someone can't travel, then we have accommodations for that as well. So they're not penalized for having a comorbid condition that prevents them from traveling or some other type of barrier. So it isn't intended to be such a stiff penalty just because they can't travel. So we try that first if they're willing to do that, and if they can do that, physically do that. If not, then we also accommodate them to try and get them to another Centers of Excellence, a Tier 2 provider to take care of that for them. So we really try and coordinate all of that. I would say one of the challenges that we experienced early on when we implemented the Centers of Excellence program was the post-operative care. So moving someone back from a Centers of Excellence facility that might not have been in their community and getting them back into their local provider for that care. And so it's taken a lot of coordination between Anthem and the nurses that help us do this at Anthem, the surgeon, and the local provider community. I think we finally got it all figured out, but that was really where the challenge was. It's not getting them to the high-quality facility, getting the great services there. The challenge for us is really getting them back into the local provider community. But it's working, and it seems to be something that I think that barrier has been worked out for us.
David?
Follow up with the same. Anthem has a concierge service which provides all the travel arrangements. Also, again, the same, if they're not allowed, if they have a chronic condition that doesn't allow them, they would get a medical exception, which, wouldn't force them to use the facility. So they could use something in the community if it was too far. And in California, luckily, we have enough facilities which are reference-based pricing regionally. That only happens in a very small number of facilities in Northern California where we'd have this kind of issue.
And actually, this question goes in the other direction. In the examples provided today, we see large insurers pushing for competition in procedures for which there are a lot of providers in an area. Do you have any thoughts on how this model might work in areas with just one or two providers and a small insurer network? Or is that what you find yourself addressing when you have somebody in Eureka?
Right. So, I mean, that's the challenge, right, of having enough regionally located, geographically dispersed, reference-based pricing facilities, and then having to have that travel and the companion package. And so, in terms of the impact of that, in terms of on the market, well, if there's only one facility and they're either meeting or not meeting, so it's, it's a little difficult to look at the variation in a region like that.
Yeah, I was just going to comment that if you have only one or two providers who can perform a procedure in a geographic area, if there is variation, which most of the time, if it's really only one or two providers or very few, they're clustering around each other, so you don't see the same variation, and therefore this type of pricing doesn't necessarily have the same impact for those providers, and it won't have the same kind of if you think about it, then you could end up in some kind of antitrust issues where if you have two providers and they're agreeing to either set or be close to one another on price. I mean, we get into a whole nother area of complicated issues when you're really only talking about where you don't have competition and you only have one or two providers who can perform a service. So it's not likely that these will occur there.
Okay. We have only a few minutes left, and I ask you to spend those minutes not only listening to the Q's and A's, but also filling out the blue evaluation form, if you would. We have another California-centric question here. How about, you've got a market in California that is heavily penetrated by HMOs, and the questioner wonders how the reference-based prices for Anthem's PPO compare to the prices in California HMOs. I got the prices that they pay.
Well, the HMO in California in general is significant, although it's actually decreasing gradually over the past few years, and the PPO is increasing overall, but there's still a very large number of HMO members. In most cases, as far as Anthem goes, the hospital pricing is a contract between Anthem and the hospital. So the professional component is where the capitation occurs on the HMO side, with the exception of about 15% of our network, which is in a full risk or more of a global capitation setting, where they contract with the hospitals. So the answer, in short, is that the HMO is currently not part of this initiative, and the prices paid at those institutions are the prices that the standard Anthem price.
And actually, this is a related question, at least poor country lawyer thinks it's related, it might not be. Why can't reference pricing be part of the carrier network contracting negotiations, that discounting up to the reference price versus usual and customary? Is that a reasonable question in this context?
Well, first of all, I'm a physician at heart, so I'm not sure that I want to venture into that. But I think you're asking, should it be part of the normal contractual negotiation, or rather than the negotiated price that is agreed upon between both parties? Is that the essence?
I guess that's right, that as you establish
Right.
a network that's willing to meet that price, can you leverage that into going to those who are outside that range and negotiate that as part of your new contract?
Well, I'm probably not going to venture too far into that, other than just to re-emphasize the fact that there was that pressure on the non-conforming institutions with the CalPERS initiative to actually bring the prices down, which actually happened without it being a direct goal. So it may well be that it could be effective. But
And I think from a payer's perspective, it's where we want it to go, right? So we want to be able to bring the costs down of all of those services in a particular category. So hopefully, target pricing or reference-based pricing is eventually going to lead us there. It's just one of the initiatives trying to get costs more aligned in a community.
I think it's really important to understand that, I mean, reference pricing is ultimately a benefit strategy. It's not a payment strategy. So while you are capping the payment, you could still pay for it on bundled payment or fee-for-service or in other methods. So reference pricing is a benefit design. So while you know, CalPERS, I don't want to speak for David here, but CalPERS implemented reference pricing without having to renegotiate contracts, and Anthem didn't renegotiate contracts during that period. They looked at the data and they set the benefit design price at $30,000, and then hospitals moved accordingly. And then surely in, I would imagine, in subsequent contracting cycles with those facilities that were either outside or at or below, that becomes part of the conversation. But you don't have to implement reference pricing through a contract negotiation, although once it's occurred, it probably does become a part of it. I think there's a question.
Yes. You want to get to a microphone? Right behind you.
Right now, I'm a Taft-Hartley fund, but anybody who has a relationship with a good carrier like an Anthem or the Bucas, they say, we'll give you a guaranteed discount of 60%, but it's based on the usual and customary. And what I'm suggesting is we would have a lot more manpower if our carriers weren't just negotiating on my behalf or Kroger's behalf, but on their book of business and telling some of these facilities, we will take a 60% discount, but up to a reference price as opposed to the usual and customary, which is more supply driven. And so it's a really kind of out of the box way to think, but it's something I think that everybody in the room could benefit from if they have, you know, stronger negotiations while we still have a chance before network negotiations go away, because everyone in the country is going to have insurance and a hospital won't take a discount anymore.
That's a very improved formulation of your question from mine. And does it elicit some further response from many of our panelists?
Again, the point I would make is that that this whole area of pricing has been changed as a result of the, let's say, the shroud has been lifted. And so the previous discussions that occurred on discount off the desired target price were discussions around the argument about percentages off. Now the discussion is different, and those high-priced institutions, from my own personal experience in California, are aware of the fact that their prices are now out there and can be seen by the public. And so it is a different discussion to the extent that the endpoint you've described, I can't speak to that. I'm not expert at that. But I believe the nature of the discussion has changed because of the fact that when the target prices are put out by these institutions, they could be recognized as way out of range of averages and reasonableness. So I think it's a positive. I'm not sure we're exactly where you want to get to yet.
All right. And by the way, one of the best illustrations of the impact on the non-participating hospitals is in the chart, and we've heard some discussion of this before, but Jamie Robinson, and we have our friends at NICM, thanks for these very readable one-pagers summarizing Jamie Robinson's article. There's a lovely chart on that second page that shows you the impact on the pricing of these services in the hospitals that were not participating in the CalPERS experiment. So, yes, Bob.
Bob Griss with the Institute of Social Medicine and Community Health. With all the discretion that the payers have in setting reference pricing that you've disclosed in this panel, and with the tendency of employers to cost shift onto employees, usually in the form of greater deductibles or co-payments, what are the protections for consumers from reference pricing, which sets a standard price and expects the consumer to pay anything over that reference price? It seems like a very dangerous precedent, even if it's in the interests of the payer in the short run. You haven't given any indication that this is a way of actually reducing total health care costs. We don't know whether the hospital is going to follow this procedure with regard to other payers or whether they're going to shift those costs onto other procedures. And I'm not sure how comfortable we should feel about this particular short-term strategy to help payers reduce certain costs. The panel itself is telling one story, and we don't have on the panel providers or consumers who have been discriminated against because their unique needs did not fill the, you sort of assume that quality remains the same, but in fact that may not be the case in most healthcare situations.
Well, for us, I think it's about being an informed patient, and it's completely voluntary for our associates and their family members to choose where they get care. So we don't tell them they have to go anywhere. The choice is theirs. And they have an opportunity to be informed before they obtain a CT scan or an MRI or get a particular prescription, and to make a choice as to whether or not they want to stay under the target price or if they prefer not to. So the choice is completely theirs. It's about, for us, it's about information and about helping them be informed consumers of healthcare and to make a choice from that perspective. So they know whether or not they're going to be paying more if they choose to do so.
Go ahead, Michael.
Yeah, no, it's a very good question, and I would say to the issues of patient protection, there is the protection that if the enrollee or the member stays within the defined reference-based network, then their share is fixed as to whatever benefit structure they have within their employer, with their employer. The only time they would be subject to additional cost is if they went outside the network. So I don't think it's necessarily bad in that sense. The quality issue is relevant, and I agree that when you're talking about quality in general, there are a large number of metrics out there, and there are a few hundred that have been developed by various prestigious organizations, the NCQA and the NQF and so on. But when it comes to specific quality issues within these very detailed procedures, such as hip and joint replacement and so on, there's a lot of quality metrics that need to, or a lot of quality information that hopefully will come out of registries. What we have at the moment is not completely adequate. So in terms of the overall success, I would just say that there are a number of initiatives that have been put out there, and there are various organizations that describe various initiatives for bending the cost curve down. Very many of them have failed. And this is one of the few that at the moment has had some success. And it's had success as well documented, not just by CalPERS and not just by Anthem, but by an impartial third party here with the health economist at UC Berkeley. So I think there is some validity to their study. I'm pretty sure it is. These are very good researchers. And I think it is a success story. Now, whether or not it can be replicated across the country or it's going to repeat itself, that remains to be seen. But it has been a successful initiative, and I think it, I mean, I'm biased, of course, but I think it has done something to push the knowledge and the practice of healthcare delivery along.
Go ahead, David.
Okay. CalPERS is extremely sensitive to this question, given who we represent. And in fact, in the Jamie Robinson article includes an analysis of the out-of-pocket to the payers. I didn't include it today because it gets a little complicated talking about coinsurance, copayments, deductibles. But we did see that the out-of-pocket actually went down to our members over the time with the implementation of the program. And in general, if you think about so in that case with hips and knees, the deductible plays a big role in terms of how that out-of-pocket hits you. Something with the colonoscopies, the cataracts, you know, the coinsurance still plays a role there, and so you know, the lower costs are going to benefit you your out-of-pocket, and so that is going to be included as well as when we do our follow-up economic analysis of those 3 other procedures that we're doing on reference pricing. In terms of total cost, that was also included, looking at out-of-pocket plus the net pay and the allowed costs, and so that went down dramatically as well, as I said, for the hips and knees, and that may have been due to the deductible being reached in a number of cases. And then I think your last part was a little bit about talking about the bubble. If you push down on the balloon here, it comes up over here, and so I think that's just, for CalPERS, is something we'll have to look at in the future and be aware of and be concerned about.
I just wanted to comment that I think there is awareness on behalf of the payers and the purchasers that this is somewhat of a short-term fix, but it is one of the few short-term fixes that actually is seeing positive results. And so in the absence of being able to look at the total and being able to bend the total cost curve down, I think the strategies are they have to be a little bit more piecemeal. So it's not that we're not conscious of the impact that it could have. It's just that sometimes things have to occur incrementally, and as Dr. Bellman said, some of the incremental things haven't worked so far, and this is actually an incremental step that is starting to work, and then we'll have to see what lessons can we learn from this to look at the more total population costs and the total costs and not having that cost shifting occur in the balloon impact. But part of this is disruption and innovative disruption that can help with short-term costs, which we're all struggling with, and then learn from that to see what are the long-term lessons and strategies we can put in place.
All right, well, that is a fittingly big picture end to this discussion. Final comment anyway, if not the end. This has been quite edifying for your moderator anyway. I learned an awful lot about the way this mechanism works and might work for others in a similar situation. And I'd ask you to, while you're filling out the evaluation forms that you've not had a chance to do yet, note that we are indebted to our friends at WellPoint for helping us think through this session and put it together. And for your great questions, which covered a number of aspects of this that weren't all that clear. And finally, ask if you would join me in thanking our panel to help us understand this concept.